Do that right now. Yeah, so it's kind of like when we talk about our physical health, right? Being physically healthy or physically unhealthy, and the same way that we strive to be physically healthy and we do certain things and take certain measures is the same way that we would do with our physical health, with our mental health, right? So that's why things like having access to good quality foods, being able to have access to physical movement, good coping mechanisms, not living in stressful environments. Those things really do help us to be mentally and physically well. The other thing is both exist on a spectrum. So again, we can have really good mental health, we can have poor mental health days, we can have a diagnosis of anxiety, but it be mild or moderate or severe. Everything exists across the spectrum. I think that sometimes, and we'll talk about this when we talk about the diagnostic statistical criteria for a diagnosis, that oftentimes, even though these are evidence-based tools and approaches, oftentimes the experience is very individualized and it doesn't necessarily look the way we think it will. And every person's experience is very different, right? So it definitely exists across a spectrum. Um, yeah, and again, like being mentally unwell can potentially lead to mental illness or not, but that in itself is probably not what's going to cause a mental illness, right? Like we know that there's a variety of different risk factors at play there, but if we do have diminished mental health, or if we're under chronic stress, or we're experiencing chronic trauma or traumatic experiences, could definitely lead to a diagnosis. Anybody want to add anything to this before we move forward? Okay. So, what are the social determinants of health? Can somebody offer me a definition, or just tell me what they think the social determinants of health mean? Any ideas? Diana, go ahead.
I was going to say the areas of our lives that impact our health.
Mm-hmm,
So, our economic and socioeconomic status, uh, our education, um, our income, our social
mm-hmm,
status, all those various things that we need to live impact the quality of whether our health is going to be poor or not,
mm-hmm.
generally speaking.
Exactly. Yeah. Yeah. It's the social factors that make people sick, right? These day-to-day things, these necessities that we need as humans in order to be able to not just survive, but thrive and be healthy and be well. And it definitely, um, is also related to access and barriers and different things that literally make people sick. So, this is just a little word kind of diagram um, that shows us some of the different ones, right? So, income, which is what you mentioned, is one. Disability, employment, working conditions, our sexual orientation, housing, education, Indigenous or Aboriginal status. Are we food insecure? Do we have access to healthy living places, gender, social inclusion, race, identity? All of these things. Are social factors that, if people are not experiencing health equities, if they don't have access, if there's barriers, can make folks sick, both physically and mentally as well. And I think there was a comment in the chat where Adriana said gender, ability, and race. Yes, exactly. Those are great examples. So I thought this was a pretty good diagram. It just breaks it down basically. And um, so we have here economic stability, so employment, right? So are people unemployed, underemployed? Are they being, uh, are they working in precarious jobs that are dangerous, that potentially are low pay, right? Income, are people earning enough money to be able to sustain a good quality life? We know that in Toronto, the cost of living is extremely high, and many people are not able to make ends meet, right? Expenses, inflation, things like that, debt, any medical bills. Not everybody has OHIP coverage. Not everything is covered under OHIP anymore. And that can be, especially if you don't have private health insurance, that can be a big barrier. And any kind of economic support, right? Your neighborhood, your physical environment is a big one. Housing, like are people living in good quality housing, which we also know that decent and affordable housing is essentially non-existent in Toronto right now. Housing is a huge issue. Transportation, like, are we living in places where there's public transportation? Is it adequate, right? Or are we waiting hours for a bus to come by? Are we having to take multiple buses and a subway because we're living in a place where transit is not fully developed, even though it's a North American country, which boggles my brain. Um, safety is a big one, right? Are we living in safe communities? Safety, particularly for anybody, particularly for youth and children, is a really big one. When children are living in unsafe neighborhoods, it directly impacts their development, their growth, their well-being. Parks, are there access to green spaces, trees, parks, places where people can gather? Even just having access to grass and trees and green spaces is something that a lot of people, particularly folks who are living in lower income neighborhoods, don't have access to or don't have adequate access to. The walkability of a neighborhood, right? Like, are we able to walk around? Is it a neighborhood that's really designed for cars? Are there bike lanes? Not everybody, can afford to drive. So what does that mean if people need to take other modes of transportation or need to walk from a health and wellness standpoint? And walkability is a big one. I know that when I worked in Flemington Park, which is those of you who aren't familiar with the community, but it's right at Don Mills and Eglinton. And it is a very high traffic area with lots of cars, and the DVP is there, the Danforth is nearby, so it's very trafficy. And the walkability, like, you don't realize it until I was working there, and I would, walk to the school, walk to the library, go for meetings, go to programs, and you're like, oh my gosh, like, there's nowhere to walk. And it's a highly densely populated community where a lot of the people who are driving in and out are not people who reside there, right? So if you're living there, chances are you probably don't have a car. You probably are walking to and from, and it's very unsafe because it's not set up to be friendly to the quantity of people, pedestrians, and the number of cars that are coming through the area at a given day. Education, literacy, language, early childhood education opportunities, any kind of vocational or higher education training. We know education is a really big barrier. Oftentimes, people will get stuck into precarious forms of employment because maybe that's the only, level of education that they can access due to accessibility. So, like, for example, if I look at healthcare, right, someone may be able to access a diploma in personal support worker, but maybe doesn't have the means or the ability to go further along and maybe become a registered nurse, right? And so we know that that keeps people in poverty because it keeps them at a certain level of precarious employment in comparison to being able to access higher levels. So all of these are examples of social determinants of health. Food is another big one. Hunger, access to healthy options. Are there good food options or grocery stores in neighborhoods? We know that fast food joints, poor quality produce tends to be more prevalent in lower income communities versus if you look at more affluent neighborhoods, you'll be able to find healthier options, better produce, quality, all of that. Social and community contacts, so being integrated socially, having support systems, are people engaged in their community? Is there any form of discrimination against them? And then healthcare, right? Healthcare coverage. We know, like I said before, not everybody's covered by OHIP. A lot of undocumented folks really fall through the cracks and either don't access healthcare that they need in order to be well and be alive, or they end up having to pay for it and come up with like really big medical bills. provider availability, we know that this is a big one in Canada. We don't have enough doctors, we don't have enough specialists, and and then that is further. So it's a bit better when you, again, when you go to other neighborhoods, or if you have access to a car and you can drive out to see your doctor somewhere else. But for people who are really confined to their communities because of accessibility issues, they're stuck with what they've got, right? Which is often not adequate. Cultural competency is really important of providers, which we often don't have enough of, and then the quality of care. And the bottom chart here just tells us what are the outcomes as a result, right? Does anybody want to add anything to this before we move forward? Yes, Ayana, go ahead.
Oh, no, I was going to comment on what you mentioned about the Don Mills Overley area. I work in that
Mm.
area. I work at
Yeah.
Netflix, so I'm in that area all the time, and
Oh my
you're
gosh.
exactly right. And the point that you made about the food, or like, I almost feel like it's the mall, if that's what you want to call it, it's a food
Hmm.
desert. Okay, they've
It
got food
is.
basics, but like the
No.
stuff they have in that area is ridiculous. It's so lacking, as you said, for the amount of people that are in that neighborhood. It's pretty sad.
Yes.
Not everybody can afford a Costco membership because the
Nope.
Costco's right across the street, right? And you're
Hmm.
right. People like myself, I don't live in that area. So the people that are there, causing all the traffic in that area, they don't live in that area. Like as soon as my workday is over, I'm gone, right? I can't wait to
Right.
get home because there's so
Yeah.
much traffic, but
Oh my
it's
gosh, I
pretty
know.
sad. It's really sad.
Yeah. Actually, Flemington Park and Thorncliffe Park were identified as a food desert. And when I was doing community work there a few years back, a big part of what, and probably still a big part of the work is around food security, because there's that Sunny's grocery store in the plaza, which a lot of community members complain about the quality, the
Yeah.
pricing.
Yeah.
There's the food basics again, which is in Thorncliffe, which is a barrier. A lot of people from Flemington tend to not go to Thorncliffe and vice versa.
Yes, yes.
So, and even the food basics is full of like processed foods and terrible
Oh, it's
quality.
disgusting in there. It's really
Yeah.
disgusting. I
Yeah.
have
Or
to be
there's,
honest with you.
it is. It is. And then there's the Metro, which is like kind of closer to Lawrence, but that's inaccessible. That's super expensive. So
Hmm. Hmm.
it is a big food desert that's
Hmm.
been on the radar of a lot of community workers for quite some time. So I appreciate you sharing your experience with it as well. Thank you. Adriana.
Yes. So I was thinking that it is interesting to see how the social determinants of health, they all can intersect very
Hmm.
negatively. For
Yes.
example, let's take the case of a person who doesn't have a job. So that person may have less access to housing, less access to food, and that may impact their physical health, their education, because no money, no access to books, to courses, to for like like education in general, in general discrimination. So it's like a whole combo. Like they
Yes.
don't. It's hard to see them independently, but they are constantly interacting.
Absolutely. Absolutely. Yep. And yeah, the more social factors that people are impacted by, the worse, I guess, the health outcomes may be. That's an excellent point. Yeah, that's great. Anybody else? Okay. This is something that I'm sure we're going to draw on throughout this course, and we'll come back to this. So, um, what I have next is a scenario. Those of you who have had me before know that I love my little case studies. So just to kind of put the social determinants of health into practice, if you will. So John is a refugee who fled persecution from his home country due to his sexual orientation. He currently rents a room in an overcrowded home in Toronto, a very dangerous neighborhood where gun violence is prevalent. He is on social assistance and his income barely covers his expenses. John is educated as a lawyer back home, but his education is not recognized in Canada. He recently started hanging out with a few of his roommates. They like to drink every night. John, who never enjoyed alcohol in the past, started drinking with them on a regular basis. He says it helps him to stay calm. So, what would you say are the social determinants of health? that John is being impacted by here?
Um, he's being influenced by, addictive behavior, I guess, with
Okay.
the drinking.
So there's some
Um,
substance use there, yeah, as a coping. Mm-hmm.
the lack of him being able to, practice his field of work,
Yep.
because of not having the proper or adequate education in the country that he's migrated to.
Mm-hmm.
So
Yep.
that would also contribute to his lack of income.
Mm-hmm. Mm-hmm.
Yeah, that's my
Excellent.
contribution.
Thank you, Natasha.
No
Anybody
problem.
else? Oh, let me just check the chat. Uh, okay, sexual orientation, immigration status, physical health, safety, feeling so isolated. Yeah, for sure. Low income, no family, trauma, PTSD. Yep. Yes. So, his sexual orientation is definitely a social factor, right? And is a lack of support, yes. Housing, we can see housing is an issue. He's renting a room in an overcrowded home. Safety, like someone said in the chat, right? So he's in a neighborhood that is dangerous. And I'm sure for someone who's fleeing persecution, that can't be good for his mental health and his pre-existing trauma, right? He's, unemployed but highly educated, so that's an issue. It doesn't say where he's a refugee from, but we don't know what his race is, but he could be a person of color, and then facing discrimination as well as an added layer there. So that kind of goes back to what Adriana said earlier about the intersections. And yeah, like he's isolated, he's trying to feel connected socially, and he's also struggling because he doesn't have any supports. Therefore, the drinking comes in as a coping mechanism, which we often see, especially for people who have undiagnosed or untreated trauma, and then have all these other barriers that they're being faced with upon arrival to Canada. So yeah, that's exactly it. Thanks, everyone. So next, we're going to talk about the DSM-5, the Diagnostic Statistical Manual. So this is a diagnostic tool that clinicians will use to diagnose, those of us that do diagnose. It's published by the American Psychiatric Association. It's had various versions since it came to be. We're currently on the 5th edition. I'm pretty sure that the next edition is like in the works, if you will. So some of the things about the DSM, it's, got a lot of pros and cons. So as registered social service workers working in mental health, as a psychotherapist like myself, we do not diagnose. It's not in our scope, but we use the DSM. At least I use the DSM often to help me better understand, or to use it to, to create like a case conceptualization for my clients after I've assessed them. And but it has its critiques and its limitations. So a lot of clinicians and folks in the medical field have criticized the DSM for pathologizing like normal human behaviors and experiences. So, for example, like grief or shyness, or tantrums can be seen as things that are normal parts of life, but the DSM kind of makes it into a diagnosis or something. There's also some belief that the DSM and the writers and the creators are heavily influenced by the pharmaceutical industry. And so, if there are more classifications of illnesses, therefore there's more diagnoses, which means there's more access to medication, which is profit, right? I don't know if that one's true or not, but it is one that I've heard and people will say. Another one is that there's a lot of cultural bias. So the critique is that the DSM is really built from like a Western centered lens and doesn't take into consideration other like it's limited applicability for other cultural groups, right? So we know that this is a very Western medicine model. The types of treatments and therapeutic strategies that I will be teaching you in this course are coming from a Western model, but we know that this isn't the only way, right? And this isn't the only um, uh, wealth of knowledge around, treatment and mental health. And there's different views and different techniques and things in other cultures. So and there, people will say that the DSM is very limited in that way. The other thing too is it can cause labeling, stigma, discrimination if we're constantly, not constantly, but if we're using it as a tool to label people, does it define them? No. And so just kind of really critiquing the role that the DSM can play in perpetuating labels and discrimination and stigma. Historically, the Diagnostic Statistical Manual has been controversial. Homosexuality was listed as a mental disorder in the DSM until it was removed in 1973, I believe. So not that long ago. So just different little things like that. It has evolved quite a bit, and it is something that continues to evolve as research and knowledge and language changes. The other thing too is when we broaden this criteria of certain symptoms of a mental disorder, it can lead to misdiagnosing or overdiagnosing people too commonly or too frequently. So that's another frequent critique of individuals who use this, particularly who use it as a tool to diagnose. I personally agree with some of these critiques. Like I think from this Western centered model or approach is very relevant because it just is not reflective of other cultures and other perspectives. I think it can lead to labeling sometimes, so that's why I personally think it's great to work without labels, even when we know that there could be something there. I mean, I can't diagnose anyways, but there's in my experience, I find that sometimes folks feel really empowered and liberated when they know, okay, I was diagnosed with bipolar disorder. It makes sense. I feel empowered. Now I feel reassured. I know where this is coming from. And people draw strength from that. Sometimes people feel labeled. People feel like, oh, shame. This is going to define me now. And it sort of derails some of the other areas or the work that they're doing on some of the other areas of their life, which are also relevant, right? So I think I've seen it go both ways. I mean, not because I have diagnosed people, but I've referred for folks to be diagnosed. Sometimes if they're open and they're interested in that, and that's what they want. So, any questions about the DSM? All right. So, a couple of discussion questions for the class. Do you think that social workers and social service workers who are working in the field of mental health should be able to diagnose? Do you think that we should be given that scope? It's one that has been up for debate quite a number of times, particularly those of us that work as clinicians, to be given that scope. Okay, so for social workers, not social service workers, with more training. Okay, yeah, for sure. SSW alone, I don't feel is enough. Okay, Adriana, yeah.
I think that it's important for social workers and social service workers to have basic knowledge of conditions and illnesses that can impact physical and mental health. However, diagnosing, maybe using it as a resource to refer the client to a professional, I think would be the best. I think that we would need more preparation to be able to diagnose and treat, because diagnosing without treatment, I think it's kind of like an incomplete approach. So maybe having that knowledge to refer but not to diagnose, I think it's the best approach.
Okay, all right. So what I'm hearing is, as an SSW, could be a bit of a limited scope. So maybe with added training, and so at the clinical level, we are trained. So though folks who do like their masters in social work, let's say, or people who study counseling and psychology, like I did, then you do learn, and we'll talk about even assessment in this class, right? So you do learn how to assess, what are some evidence-based tools that you can use to help with the assessment. So, I've done assessments for anxiety, for depression, for PTSD, for a broad range of different things. And through that is essentially with added training. I still have a limited scope, but to a certain extent, like I do a lot of the assessments for our clinical psychologist. Like I literally sit there and facilitate and write the report. He just looks it over, gives his clinical kind of stamp of approval, signs it. So what I guess what I'm getting at essentially is that we are kind of doing, like I'm doing his work, right? But I just don't have that stamp to say this is what it is. Now, I agree. I think, um, I have a pretty good, I would say, knowledge base of mental health because I've been doing this work for 5 years now. And I, went back and expanded my scope in terms of education. And so I think that I probably could do a few, like I could probably diagnose one or two things, maybe not everything. I would need more training, right? Um, but so what would you say are, let's say with additional training and getting a master's in social work, what would you say are the benefits of being able to diagnose as a social worker? What would be the benefits?
Maybe helping the clients in a more holistic way, like a more comprehensive approach
Yeah.
um, to mental health issues, for
Mm-hmm.
example.
Yep.
And since getting help from like a psychiatrist is so difficult in this in our system, maybe getting those services from social workers would be, or social service workers with the training that you are describing, I think would be really beneficial for especially vulnerable populations who do not have access to like all these private services.
Yes, exactly. Yep. 100%. The accessibility is a big piece of this, right? Like, so social workers are in community, social workers are employed in schools, social workers are employed in hospitals, community settings, community health centers, and that is often an easy barrier-free way for people to access healthcare or mental health support. Now, I say that because also like there's barriers to that because there's wait lists and there's not enough of those services. But if people are lucky enough to get through, they've made a connection. It's barrier free. It's free of cost, probably in their community, but then there's limitations there from the clinician standpoint. So then you've got to refer out again, right? And sometimes we lose people in that. So I think somebody said like continuity of care, which I agree, Ayana. If faster access to help is another one, right? And yeah, there's an element of trust building and relationship building that comes with um our relationship and our role with our clients. So with that trust and with that relationship building, there's an opportunity there potentially, especially if there's resistance there or there's a lack of understanding there. And then again, like I've been in this situation many times where I'm like, this person needs to be diagnosed and they want me to be that person and they don't want to go somewhere else, or you struggle to figure out where am I going to send them in a more timely fashion. And some people can afford to just go see a psychologist and pay privately, or some people end up in emerge even though it's not necessarily an emergency, or some people end up in crisis, then end up in emerge, and that's how they get their diagnosis, right? And I just think like, you know, would we be able to avoid all of that if we had other qualified folks who could be able to diagnose? And in some US states, psychotherapists and counselors do diagnose. They can't bill to their insurance because their healthcare system is different, without a diagnosis. And so they have to have that built into their scope, right? So Linda's saying, I feel it is a role of psychiatrists or psychologists. However, we should be able to assess and recognize mental health challenges in order to provide support, advocacy, and referrals. So I hear you. I definitely think that coming out of an SSW diploma when I did, I don't think that I would have even known what a diagnosis is. Like it takes clinical experience. And I think clinical experience and clinical hours is just as valuable as additional schooling. In fact, a psychologist essentially has a master's with additional clinical training, and that's how they are able to have the scope to diagnose, right? So, um, yeah, I agree. I think it takes more training, more experience, and yeah. So, what would you say are some of the disadvantages? I think we kind of talked about this a little bit already, right? Just around the labeling and this fear of people being defined by it, and sometimes it is really liberating to work without labels, and you can be more effective in your work. Can anybody think of any other disadvantages? Okay. Oops. So why do you think we're not able to diagnose? Why do you think that maybe at a clinical level, without added training, there's still resistance, or this they're not able to give this us in our scope? Why do you think that is? Yeah. Well, I mean, a psychologist can diagnose but not prescribe. So that is still okay, like that's still a model that exists, right? Risk of misdiagnosis. Yeah, I think anybody can have run that risk of, even doctors, medical professional specialists, right? There's always a risk there. But sure. I've heard that really what it comes down to is pay, right? Like then we would have to make more money, and maybe that's not something that people want to do, or want to facilitate for social workers to make more. I don't know. Um, but I think that it's what I would argue is it's not very or not seamless, but it's not consistent, right? So like different provinces have different criteria, different countries. So like I said, some places in the US you can, here you can't. So I think there's different reasons for it. I don't know who the decision makers are, but I wouldn't be surprised if there was also like a power dynamic component to it when it comes to equity and pay. um but yeah. All right. Okay, that's it. Thank you. So now we're going to move into talking about some of the more common mental health issues. So I wanted to start off by talking about anxiety. So anxiety is it is the most common mental illness. Lots of people suffer from anxiety. There's different types. Um, some levels of anxiety are normal, right? Like everybody might feel a bit of anxiety before a test, or everyone might feel anxiety before a speech or before a job interview. But this is when it becomes, when it interferes with our psychological functioning, when it, prohibits us from being able to live our lives, and when it's debilitating. Again, anxiety also exists across a spectrum, and it can be very individualized for different people. Some of the more common, are the various types. There's a GAD, which is a generalized anxiety disorder, which is a common one. It's not specifically tied to any particular like phobia or fear. It's more just this generalized feeling of anxiety that people experience on a daily basis, where their body and brains and nervous system is dysregulated, and is always perceiving everything as a threat, or they're in constant flight and fight mode. GAD is very treatable. Most anxiety disorders are very treatable with cognitive behavioral therapy, medication, mindfulness, right? And like relaxation techniques. Social anxiety is when people have, phobia of social spaces. So, not being able to go into crowded places, not being able to socialize, feeling really threatened in social settings. I see this a lot post-COVID. I think we talked about this last week. A lot of young people really struggling with social anxiety, especially also with the rise of the prevalence of social media. People are talking to each other less and are more plugged in digitally, and that's having psychological implications. Social anxiety, again, with some cognitive behavioral therapy, some exposure therapy is really good for social anxiety, but I think with this one it's really about reframing like these thoughts in your mind, right? So if and just doing that work around looking at social settings and what those triggers are in a very different way and from a more realistic lens. Um, I think that sometimes in therapy we say like, oh, we have to replace the negative thoughts with the positive. I personally don't think that that's realistic, and I don't think that sometimes there is no positive, right? But what we can do is reframe it so that it's more realistic, right? So we encourage realistic thinking versus positive thinking. Um, and then some people have anxiety to a specific phobia. I think I mentioned I work a lot with motor vehicle accident claimants, and there's a lot of phobia around driving. Some people don't drive at all. Some folks will drive only, to work and back, or some people won't take the highway. Just different things like that. And with specific phobias, again, like some of that reframing. Realistic thinking is really helpful, but also exposure therapy. So slowly and safely in a supervised way, exposing the person to the threat until they feel comfortable with it again.
So Anna, when you say realistic,
Yeah.
what do you mean by that? Can you give an example?
Yeah, of course. So let's say the person is like, I'll use a car accident as an example. So, some of my clients will be like, oh, I can't get back into the car again because I'm fearful that, like, if I drive again, I'm going to get into another accident. Or if I take that road again, it's something bad's going to happen, right? So that's really thinking that is um, generated by fear, and there's not really a lot of truth to that. So I'm probably not going to say to the client, oh, you got to just think positive and like just get in the car, it's not going to happen again. But what I would do is say, let's talk about the situation more realistically. So realistically speaking, the chances of you taking that road and something happening again is low, right? um like the chances of you it's late, so it's hard for me to think off the top of my head. But you know what I mean? Just like reframing it so that it's realistic. Or sometimes people think in absolutes, right? So it's like, I'll never get a job because I bombed both job interviews. And it's like, well, I don't know about never. So let's talk about that in a more realistic way, right? I'm doing the best that I can in my job interviews. I'm preparing. Some of it is just not in my control. If I'm not getting it, maybe it has to do with the fact that there were other candidates, or maybe somebody had a friend in the company and they got in and not me. Like there's other factors outside of what the anxious mind is telling us, and so we encourage that realistic thinking. Does that make sense?
To a degree, yes, but I just don't know what would you say to them? You know what I
to,
mean? Like,
to encourage realistic thinking.
yes, yes.
Yeah. So that's what I would say. I would ask them to challenge their beliefs. So if the belief is like, I'll never get a job interview, or I'm not good at this, or, I'm always, if I get in the car, I'm going to be in another car accident, then you want to challenge those beliefs and just look at the situation more realistically, which is going to help the person to feel maybe less sad about it, less anxious about it, and just develop that awareness that our thoughts can be influenced by our feelings, right? And so is it really that you're never going to get a job, or that you suck at this, profession or job interviews, or is it that there are other factors there that your anxious mind is not telling you that we need to factor into this?
Got it.
Yeah.
Thank you. Thank you.
Thank
Yes,
you
that
for
makes
bearing with me as I tried
no
to put that
problem.
together.
Thank you.
You're very welcome. So we'll talk about it. And that's like really realistic thinking, challenging negative thoughts, challenging anxious thinking, reframing is all embedded in CBT, which is what Melissa M is just saying in the chat, right? It's cognitive behavioral therapy. So cognitive behavioral therapy challenges our thoughts, our feelings, and our behaviors and recognizes the relationship between the three of them. So if my thought is that I'm going to get into a car accident if I drive, my feelings are going to be fear and anxiety, and my behavior is I'm going to avoid. So you want to tackle all of those domains so that the person can reduce that anxiety and, you know, perceive the situation in a more realistic way. Just going to check the chat. CBT is a powerful tool. Yep. CBT. Yeah. Okay. Change the way I look at things even now. Yes, and that's just it. And one of the components of cognitive behavioral therapy is practice. So what you'll do is, you know, and so we have a lot of tools and little handouts that we can provide people for like realistic thinking. And part of one of the principles of cognitive behavioral therapy is practice. So you talk it out in therapy, you do the work, and then, you know, you go home and you practice it until it becomes second nature and you don't really have to write it down, as you're saying, Melissa. So that's great. Okay. Some people, if their anxiety is very extreme or if they're really struggling with a lot of intrusive thoughts, which is common with anxiety, especially with like obsessive compulsive disorder, where people are plagued by a lot of intrusive thoughts. And it can be difficult to, you know, work through them or ignore them, especially if they're that debilitating, then medication is something that most likely will be needed, because I often find that if the anxiety is too severe, we can't get a baseline in therapy. Like we'll do the work in therapy, but then the person tends to regress because the physical symptoms of it are just too profound that it doesn't, like the cognitive work can't resonate, right? Okay. Anybody want to add anything else about anxiety? This is a very high level introduction to it. Okay. The next one is schizophrenia. So schizophrenia is not one that I particularly have a lot of experience with. Most folks with schizophrenia don't typically, at least from my experience, engage in psychotherapy. Sometimes I think if it's well managed, depending on how severe or where people are on the spectrum, I'm sure it can be. But sometimes, again, without medication, without the proper diagnosis, it can be very challenging for therapy to be effective because the symptoms can be very persuasive, right? And quite debilitating. Um, with schizophrenia, we usually, in most cases, symptoms, people who are predisposed, so there's really a biological or genetic component to schizophrenia. Most people will see that symptoms start to emerge in late adolescence, early adulthood. Sometimes it's brought on by a major significant change. So, like if I'm going off to university in my early 20s and I'm moving away, or, you know, if parents get divorced or something like that, or you leave the country, move somewhere else, those significant changes combined with being predisposed can uh, can cause the onset of schizophrenia. So oftentimes we'll hear people start noticing that their significant other, somebody, their loved one, has started noting some changes or behaving a bit differently in that like 18 to 22, 23 age range. Caused by biological, environmental, social factors. Sometimes schizophrenia or, you know, types of or symptoms of schizophrenia can be caused by head trauma. So, you know, somebody who, let's say, has a really traumatic head injury or some kind of damage to the brain can cause things like delusions, hallucinations, disordered thinking, that didn't exist there before. Again, it exists across the spectrum. The thing with schizophrenia is that it can be well managed with medication. This is one of those mental illnesses where, in my opinion, medication is almost always required, because, you know, if we're looking at very severe or persuasive delusions or hallucinations, um, people can be suicidal, people can harm themselves, they can harm others, and it's just a very poor quality of life. The problem with the medications is they do have a ton of side effects, and oftentimes they're a concoction of different things: antipsychotics, mood stabilizers, antidepressant, anti-anxiety, and all of that can cause a lot of side effects and be really hard on people's bodies, which is a deterrent for people to stay on their medication, which is why a lot of, or sometimes people will feel better and they're like, oh, I don't need the medication anymore. Um, Sometimes with medication involves a lot of trial and error. So you'll have to try different, pills or different kinds or different doses to really get it to be effective. And there's a lot of side effects. Like I hear, weight gain, just different unpleasant side effects that come from the medication. My little guy's going to sleep, so I'm sorry if you hear him crying. Um, yes, Ayana.
No, I was gonna say with schizophrenia, just from personal experience, it
Hmm.
terrifies me. Um, the entire thing terrifies me. I don't even know what to specify right now.
Yeah,
In particular, for people who, my issue with this mental illness is for people that um don't stay on their medication or
I
refuse
know.
to take their medication. So it's scary,
Yeah.
especially living with someone who has it. I mean, having to sleep
Hmm.
with your door locked or things like that, that's not normal. You know what I
I
mean? And,
know.
and that's it absolutely terrifies me.
Hmm.
Yeah.
Hmm.
I just
Yeah,
wanted to
for
say
sure.
that.
Thank you. For sure. 100%. It is. It is. It's very hard. But I have seen people, like even in my own life, who once they figure out the medication, once they get, the right supports, they have good quality lives, right? And not, yeah, not all schizophrenia is necessarily that debilitating, but it can be absolutely without the right medication. And that's why I'm saying like there's that risk, because people are hearing things like people with schizophrenia hear things like you should jump off out of that window, you should die, or you should kill that person. And when we hear in the media too, situations where people are found not, criminally responsible because they were in a state of having a hallucination or not on their medication or something like that. So, absolutely. Just gonna check the chart or the chat. Yeah, yes, psychosis. So psychosis and schizophrenia are two different things, but sometimes a diagnosis of psychosis can lead to, like, it could be like a indicator of schizophrenia. And there's definitely a correlation between marijuana use and schizophrenia. The trick is, though, you need to be predisposed. Like there is a genetic component. But what I also will say is we are seeing, and this was when I was doing youth work, um, one of the things that was identified was like that we were seeing higher rates of schizophrenia amongst young Black males in particular. And, part of it is tied to these environmental factors that we're talking about, including substance use, right? So it is definitely something that does have a direct correlation with substance use in general, but I think we do see it. So if you're predisposed to schizophrenia and you use marijuana, and for some reason, my experience working with youth and marijuana, like with youth and schizophrenia, is even though like there's something about it that gives, I don't know, is appealing, right? Maybe it helps to cope with symptoms, it helps to curb the sounds in the head. I don't know what the appeal is, but there's a strong correlation. And even though you tell, yeah, and plus they're youth, right? So they want to experiment and you know um but it is really like it worsens it can worsen your symptoms, right? Your delusions, your hallucinations and stuff. So it's really important for young people to stay away from it. Yeah, yeah, I don't think it's so like not every teenager that will smoke will get it, but it is something that, especially because we're seeing young people, younger and younger smoking, and plus other things, right? Again, these social determinants of health, these environmental factors are also a big piece of it as well. Yep. We have a presentation on this topic, so I'm sure we're going to learn much, much more about it. But this is just kind of like a broad overview. Okay, so next we'll talk about personality disorders. There's several different types of personality disorders. I'm going to focus on borderline personality disorder, BPD, and narcissistic personality disorder, because those are the ones that I see the most commonly. Personality disorders can be very challenging to diagnose, can be very challenging to treat. They can be challenging to diagnose because oftentimes people who have a personality disorder do not necessarily have the awareness, right, that something is necessarily wrong, or because of the dysregulation, like they may feel as though what they're experiencing or how they're feeling or how they're behaving is justified, right? So there's part of it is a strong barrier because of that lack of awareness. And two, it can be like you need really good clinical experience and exposure, in my opinion, anyways, to really be able to diagnose these, right? Because I think that there's certain things that it's very tricky. I would say I don't know if I'm explaining it properly, but they are very tricky. They're very common. I think that now with social media and more education and awareness, we're learning more about certain things, like how to spot a narcissist. And narcissists, and it's not to defend bad behavior, but it's a mental health issue. It's a personality disorder, right? So and it's a very challenging one. um, Treatment is quite limited. There's no medication that's like specific for BPD the way like certain things are specific for depression, anxiety, or bipolar disorder. What happens often with, let's say, BPD, is people will get different kinds of things to treat certain things. So often I'll see people on an antipsychotic and an antidepressant, or an antidepressant and an anti-anxiety, just to treat certain symptoms of it. Um, from a therapy standpoint, dialectical behavioral therapy, otherwise known as DBT, is the most effective treatment for BPD. It was actually created as a branch of CBT, but to work very specifically with folks with BPD. And then later, DBT was actually found to be effective for anything. So, substance use disorder, just any trauma, any kind of dysregulation. So, it really works as a tool and a therapeutic approach that helps with grounding and regulating people's emotions, right? And identifying healthy coping mechanisms. Problem, I guess, or the downside to DBT is it's very long. Like you have, so clinicians will do it differently. Like I practice DBT in my practice, but I don't do it in that structured 12-week program format. I just find that it's too long. It's too much of a commitment, 12 weeks plus all this homework. Like I understand that in theory it works. And I'm sure for some folks who maybe are on a different side of the spectrum, that could be engaging for them and meaningful. But I find in my experience working with clients with BPD that because their life is so turbulent, right? They're not able to cope with like even the day-to-day things. There's a lot of relational issues. There's a lot of work-related issues, right? Just because folks are so dysregulated, that oftentimes a lot of the work goes into putting out those fires and dealing with the immediate crisis or perceived crisis versus, okay, let's sit down for this hour and work on how we can regulate our emotions. So you get sidetracked a lot. So I don't practice it from that like structured model. I just pull different pieces of DBT and incorporate it into the work I do with clients. So it is the most effective way to treat it, but there are a lot of barriers to it. Um, there's 9 criteria that people need to meet in order to be diagnosed. Sorry, there's 9 criteria that the DSM identifies as common markers of BPD. And in order to be diagnosed, you need to have at least 5. And some of those are like, difficulty regulating your emotions, suicidality, self-injury, very common with people with BPD. There's an intense fear of abandonment, very anxious attachment style, deep insecurities. Um, and there's other ones as well. Just going to check the chat. Is there a correlation between females? Sorry, this little thing here
I was
is
going
not
to
letting me
ask
see.
you, Anna, what does DBT stand
Yeah,
for?
it stands for dialectical behavioral therapy.
Dialectical
Yeah, behavioral therapy.
behavioral therapy. Thank you.
You're welcome. Is there a correlation between female clients with ADHD also having BPD? Yes. I don't know the stats, like I couldn't tell you like statistically, but there's definitely a correlation. There's often correlations between there's like dual diagnosis. Often we'll see, a diagnosis of anxiety and BPD, a diagnosis of, sometimes bipolar disorder and BPD. We'll see, ADHD is one that I see more commonly than ever before. And I think it's because there's more awareness there and better understanding. But I have seen a correlation there, absolutely. The risk factors for personality disorders are genetic. So if you have a family history, one of the biggest ones is really environmental, right? So we often see people who have BPD almost always have a traumatic event or a series of traumatic events or abuse that they've suffered either in childhood or in early adolescence. That's really when we start to see the dysregulation in early adolescence or early teenagehood, sometimes earlier. And so something about being exposed to this trauma or this abuse combined with genetic and other factors can lead to a diagnosis or the development of BPD. Narcissistic personality disorder. I don't have a lot of experience treating it because most narcissists don't think there's anything wrong with them. So I very rarely see them volunteer to come to therapy. It's a difficult one, Unfortunately, my experience with narcissistic personality disorder is a lot of women in heterosexual relationships coming into my practice struggling to navigate their relationships with their partners who are narcissists. Or I often see a lot of young people whose parent or, are narcissists, and just people really struggling with how that abuse and control impacts them. And it's very hard, right? So a lot of it is really, in my experience, has been really just supporting people who have narcissistic loved ones in their life. It's marked by severe and frequent mood swings. There's this inflated sense of self. There's a deep lack of empathy, deep insecurities. Like a narcissist is deeply, deeply insecure, and will mistreat and control and take advantage of and manipulate and gaslight others, particularly people who are deemed as weak, in order to make themselves feel better about themselves, right? So unfortunately, I see a lot of or I hear of or exposed to narcissists in my practice who are abusive, who are controlling, and there's not really much as the workers we can do other than support that person, right? And meet them where they're at in terms of helping them cope with having a narcissistic person in their life. Again, narcissism, genetic, but also there's a strong correlation with trauma and abuse. Oftentimes, if we look at a narcissist story, there's some kind of chronic abuse, traumatic series of traumatic events that leads to this dysregulation that then causes this personality disorder. Does anybody want to add anything to that or ask? I'll take a quick pause. Okay, great. So next we'll talk about feeding and eating disorders. Basically, it's just marked by persistent disturbances of eating or eating related behaviors. It impairs our physical health and psychosocial functioning. Most common examples include anorexia nervosa, bulimia nervosa, and binge eating disorder. These are probably the more common ones. Anorexia nervosa is essentially someone who does not eat or refrains or restricts from eating for long periods of time in an effort to lose weight. There's an intense preoccupation with fear of gaining weight. There's body dysmorphia there. So often, even if the person is very, very thin, they will still see themselves as fat. Um, and there's a lot of health issues, or even like it has a high mortality rate and like out of all the psychiatric disorders, because people with very severe anorexia will experience heart failure, can die from malnourishment. Sometimes there's often a concurrent disorder with like a substance use issue, so people will die of an overdose, um, suicide, right? So there's different ones here. And then there's implications to starving your body, right? Like women will report that they often will see an absence of their menstrual cycle because their body's not nourished enough to produce, ovulate, and shed. And other things. Bulimia nervosa is probably more common, I would say, and it really exists across the spectrum. This one is more with like the preoccupation of weight loss. There's body dysmorphia to bulimia as well. There's some restricting. There's more like, but you also see like binging and purging, so intentionally vomiting out food, the misuse of laxatives, over preoccupation with exercise, and things like that. Sometimes what happens is people will have both or start off with anorexia, and then let's say, your family and friends are noting like, hey, I don't see you eating, like how many times are you going to say, oh, I'm not hungry at dinner time? And people may lean into more bulimia tendencies, because it's a very often secretive uh, disease that people live with in silence until other people notice, right? It's a very hard one. I think it is very treatable, most definitely, but it is one of those things that involves a lot of can involve a lot of intense therapy, and we see it kind of like an ebb and flow. Like people will do really well and then they may relapse. Also, in terms of risk factors here, um, trauma abuse is often a common risk factor for people with eating disorders. It is the whole premise of an eating disorder is embedded in control. So when our environments feel out of control and we're struggling to control what's happening in our lives, something in our brain tells us, well, this is something that I can control. And it feels like this false sense of control that then we become fixated with, that then has, potential negative health outcomes. Binge eating is kind of like one of the newer ones that went into the DSM. It's characterized as just eating a lot of foods in a really short period of time, or if you're not necessarily hungry, and that's in an effort to cope. For a while, there was resistance to put the binge eating in the DSM because it was seen as like the opposite of an eating disorder. But, actually, there's a psychological component to it, and it is something that people get diagnosed with. And again, it is something that with giving folks proper tools and coping mechanisms, and also getting to the psychological roots of the eating can be beneficial in terms of treatment. There's a ton of gaps in research in terms of the impacts and prevalence of eating disorders in many populations. There's this assumption that an eating disorder only impacts young white teenage girls, and that really is not the case. Um, and men are often impacted by eating disorders, people of color, and there's a very unique experience there that's not being documented from a research perspective. So we don't really know what those experiences are. We know that eating disorders impact the LGBTQ plus community. It's quite prevalent, yet there's a lot of gaps in research, right? So there's a lot of work to be done. And also, what I will say about this one is that we are seeing an increase in different kinds of disordered eating. It's not even just um, limited to these three that I've included in this slide with the rise of social media, and access to all this information around diet culture and looking a particular way, and so we're seeing a lot of like um sorry if you can hear my baby crying through the headphones. He's distracting me. So we just see a lot of different kinds of disorder, like people who don't eat gluten even though they're not gluten free, or the smoothie diet, or just different things that are not necessarily healthy ways of managing our weight or being healthy. And what are some treatments? Treatments include CBT, depending on the severity of the symptoms, sometimes inpatient. For people with anorexia nervosa, oftentimes they do end up hospitalized first because they have to treat the physical symptoms. So if they're severely dehydrated or malnourished, if they can't eat anymore, or if they're refusing to eat, they might need a feeding tube. Those are things that have to happen in a clinical setting. Um, so they might do inpatient, or some people do outpatient. Group therapy, there's some medications that can work really well, especially if there's a diagnosis there of anxiety or depression. Sometimes treating some of those symptoms is helpful, can help with, treating and managing the eating disorder. Just going to quickly check the chat. I was trying to find resources for someone and stumbled onto this website. It was mostly young girls who would post messages about tips. Yeah, how to lose weight, how long they have to go before they purge. I know, it's very sad. Okay, so next I'll talk about depressive disorders, which includes, major depressive disorder, premenstrual dysphoric disorder, or PMDD. I should say premenstrual, yeah, PMDD. These are just common, they're just different kinds of depressive disorders. Their most common features include sad, feeling empty, loss of, interest in things that once brought us joy, loss of interest in like intimacy or sex or being touched, um, increased irritability, increased agitation, um, mood swings, somatic and cognitive changes, low motivation, social isolation, and all of these things impact folks' capacity to function, right? There's differences in the duration and timing. Like major depressive disorder is more cyclical, but I think people mostly have like depressive episodes than happy ones. With PMDD, really what it is a depressive episode or period of time that is brought on by women's menstrual cycles. So the drop in hormones, or the fluctuation in the hormone, becomes too profound, or if there's a hormone imbalance or something there, that it actually causes severe depression, severe mood swings. But I mean, like beyond a normal PMS, right? People experience like suicidal ideations, they can't function. It's very debilitating. And oftentimes, people with PMDD need to be medicated in order to get through that time. And it's really just like the period of after ovulation, like those 2 weeks after ovulation till when the menstruation starts, where people will really feel that dip, and it causes a depressive disorder. Um, can be commonly diagnosed with other disorders such as anxiety. We often see a correlation or a diagnosis of a depressive disorder and anxiety, or depression and anxiety. Treatment includes cognitive behavioral therapy, which is really, really effective for depression. In fact, CBT really was developed to treat depression and anxiety, and medication. Almost always, I think for major depressive disorder, people are at least given the option of medication. Okay. And then next, we'll talk about bipolar disorder. So bipolar disorder is marked by manic episodes and depressive episodes. And there's two different kinds. So again, we're going to have a group presentation on this, so I won't go in too deep about it. But when people have manic symptoms, or they're manic, it includes this inflated self-esteem, engaging in really high risk behaviors like gambling or unsafe sex or substance use. There's a lack of sleep because people are just like go, go, go. They don't feel the need to sleep. They're having a lot of racing thoughts. And yeah, really engaging in like reckless behavior. Sometimes people, when they're manic, like I had a client who um, would like have this like savior complex, right? So she would be in a manic state and would, take all the clothes out of her closet and give them to like someone who was unhoused by her house, or drive, people like youth who are unhoused around to help them like get a belongings, and putting herself in these like really um, unsafe situations because she was just in that manic state. It doesn't always have to be like, drug use or really like explicit stuff, but it can be very debilitating, or to the point where people are doing things that they're not necessarily aware of. And then what happens is people will then fall into the depressive state. And then it's the like total opposite, right? Where they don't feel well, they get really depressed. There's this diminished pleasure in almost all activities. There's no motivation. People struggle to like bathe and groom and different things like that. Um, Weight loss is often a symptom, fatigue, loss of energy, reoccurring thoughts of death and ideations is a common one for some folks with bipolar disorder. Um, some people, depending on where they are on the spectrum and how severe it is, are chronically suicidal or chronically having those intrusive thoughts. And treatment includes medications, mood stabilizers, antidepressants therapy, CBT. Ayana?
I was going to ask, when the person is in the depressive state, is that, um, is it a clinical depression?
Yeah, like it's just the two kind of like the two contrasting states that people are in. So they'll have it's not really like it's like essentially like a depressive episode
Mhm,
that
mhm.
and the duration and the, I don't know the kind of like the specifics of it because they're different kinds. And it can look different for different people, right? But generally speaking, sometimes you'll get a client, someone who's manic for maybe like a couple weeks to a couple months, and then they just go into their depressive episode, which is, yeah, essentially like a deep depression.
Yeah, that's what I was trying to like. Sorry, I didn't
Mhm.
ask it properly. Like, how
It's okay.
sometimes, a lot of people get depressed every now and then. But I
Yeah.
meant for someone who is bipolar, when they do hit that low, is their depressive state, could it be categorized as clinical depression? Is their depressive state that severe that it's clinical depression? Or if you don't know, that's okay too.
I mean, I don't know if it would be classified as like it wouldn't be a separate diagnosis per se, but it
Okay.
is. It's depression for
Right.
sure.
Okay. Okay.
But it's complicated, right? Because things overlap. Like I have a client right now who is diagnosed with anxiety, depression, and bipolar disorder. But not the bipolar, there's different ones, right? Not the bipolar disorder, and I can't off the top of my head think of which one it is of the two, but not the
There's
one that where
bipolar
she
one and
has,
bipolar two.
yes, exactly. I can't remember
Yeah.
which one is what at this moment, but
Hmm.
basically hers is not marked by mania and depression. Hers is like is more on the depressive side. So she doesn't really experience manic episodes.
Hmm.
Um,
Hmm.
and so I thought, like, how, like, there's got to be so much overlap there, right? Because with bipolar disorder, sometimes people feel really anxious and they have those racing thoughts. And
Hmm.
then she's got this form that really sides more with the depressive side, but she also has a diagnosis of depression, right?
Hmm. Hmm.
So sometimes there's a lot of overlap. But so I think, yeah, like it essentially is marked by like depression. Now,
Hmm.
would it be diagnosed? I think it's just a component of bipolar disorder, so it still fall under the classification of bipolar depression, if you will.
Right. I understand. Okay. Hmm.
Yeah,
Thank you.
you're welcome. Also, one that's very manageable. I know a lot of people who live very, very meaningful lives with bipolar disorder. Um, you know, it depends on where they are on the spectrum. It depends on the severity of their symptoms. It depends on whether or not folks take their medication, whether they're in therapy. It involves a lot of like self-care and just really like putting in the work, so to speak, to manage it and to keep it stable. But it is totally possible. And the last one I wanted to talk about is post-traumatic stress disorder. We're going to talk about trauma and there's different traumas. This is just one of different kinds. But basically, are there any tools to diagnose bipolar disorder? Is that what you mean?
Any of the disorder or anxiety or anything that we mentioned, like do
Yeah.
we have tools that we use to
There
differentiate?
are tools, yeah. So there's different criteria for diagnosing. So when I do assessments, along with a comprehensive assessment, what I'll also do is provide there's like self-reporting evidence-based tools. So the ones that I can put it in the chat. Like for example, there's one called the BAI, which is the Beck Anxiety Inventory, which is really good to diagnose anxiety and the severity of it. So there's like it's a self-reporting tool, so it'll tell you like where on the scale if you've been bothered by that symptom and for how long and what's the severity of it. So usually in assessments, you'll use some of those tools. The one for depression is called the BDI. Um, and you can use those as a tool to say, okay, it sounds like I wouldn't say, okay, you scored in the severe category, that means you have depression, but I would use them to at least say, okay, there's definitely a lot of symptoms of depression here based on this score, just because I wouldn't be able to diagnose, right? There's all kinds of evidence-based tools out there that clinicians use all the time to support their assessment to help make a diagnosis. Definitely. Thanks, Nita. Yeah, so PTSD usually appears within 3 months of the event. Um, and it usually lasts like a bit longer than like an acute trauma. Re-experiencing the traumatic event over and over again. So if you're exposed to, let's say, chronic abuse or something, that can lead to a diagnosis of PTSD. Symptoms include, nightmares, unwanted, disturbing memories of the event or flashbacks of the event, people feeling and acting as if the event is happening again in the moment, feeling upset when they're reminded of it, staying away from activities, places, or people that are reminders of the traumatic event, avoiding friends and family. Social isolation is one I see so, so commonly with people with PTSD. They just can't go out or be in crowded places or hear loud noises or hear honking, anything like that. Really just puts people in that flight and fight mode and are just huge triggers for people with PTSD. Yeah, PTSD definitely, Melissa, for sure. It's a tough one. It's hard. It's very debilitating for a lot of people. Um, yeah, like loss of interest in activities. People report, like a lot of relational issues when they have PTSD because they're just like not the same or they don't interact with their family members or their loved ones in the same way. They struggle with having loving feelings, being unable to feel pleasure, constant worry, this fear that something bad's going to happen again. Having a hard time concentrating, other cognitive impairments like struggling to make decisions, struggling to problem solve, memory issues is a very common one for people with PTSD. Increased irritability, often we see anger or just trouble regulating emotion. So we see people are very dysregulated when they have PTSD. So dialectical behavioral therapy or DBT is also very effective in treating PTSD because you can help people to regulate and ground, right? Sleep disturbances, very common, very, very common. People just can't fall asleep, can't stay asleep, and really struggle. Fear fearing harm from others, fears of dying. Sometimes people are suicidal who have PTSD or are suicidal ideations. Sometimes we see like substance use as a means of coping, right? Shortness of breath, dizziness, fast heartbeat. These are all, and more. This is not an exhaustive list of how post-traumatic stress disorder can impact people, or what it looks like when people have PTSD. Any other questions, comments? I'm going to stop sharing my screen because that was the last slide. So this is, I don't know if you noticed, but probably, this is posted on Blackboard already. So feel free to go over the slides if you need to. I have not, I haven't uploaded the recordings yet, but I will do that before the weekend so that if anybody needs to review